Okay, welcome to our session about microdosing. My name is Oded Arbel. I'm a psychiatrist and the moderator of this sitting. I'm happy to present Professor Harriet de Wit from the University of Chicago. She's a professor of psychiatry and behavioral neuroscience. She received many rewards and published many studies about neuroscience and psychedelics. Microdosing is one of the biggest questions in the world of psychedelics. I tell you that my own experience is inconclusive, and many other studies question if microdosing is actually a placebo or has a substantial effect. And even though there's a widely used practice of using microdosing in the West Coast and in Israel, there are very few studies, and Professor de Wit published one of the few placebo-controlled studies about microdosing. So thank you for speaking to us and participating in our conference.
Thank you very much. Thank you for the introduction. And I'm sorry I can't be there in person. It sounds like a great meeting. So I'm the one missing out here. So I am going to talk about microdosing, and sadly, I don't have any solid answers, and there's still a lot of uncertainty, as you'll see at the end of my 40 minutes. So, but it is our job as researchers to do what we can to see whether there's any basis for the claims. So, what is microdosing? Can you see the top? There's a bar. You can see the slide fine. Is that right? Okay, so what is microdosing? And it's the phenomenon that users in a non-medical context actually report that low doses of LSD taken once every 3 or 4 days improve mood, cognition, creativity, and quite a number of other personal psychological constructs. Microdoses are a fraction of the dose that people use to trip, basically. So the microdoses are in the range of 10 to 20 micrograms of LSD, whereas doses that produce psychedelic effects are in the range of 100 to 200 micrograms. So you can see it's a fraction of the dose that actually produces a trip. The practice is very widespread, and it's had a lot of publicity. But there have been few controlled studies looking at whether there's any biological basis for this. So on the other hand, there has been a lot of public interest, and here are some of the many books that have been written on the topic. One of the first ones was James Fadiman in 2011, and that's been followed by quite a number of others. Often describing sort of phenomenologically what happens when people do microdose. And here are some of the claims that are even on the titles of these books. That and my message here is that the claims are quite broad and diffuse. So the claims are that the drug can heal trauma, improve performance, improve physical and mental health, and enhance creativity, healing, and recovery. So the claims are very broad, which is a challenge for us as researchers to know exactly what to study. So does it work? There are reasons to think that microdosing does have a biological basis, and there are reasons to be skeptical as well. So on the one hand, on the maybe yes side, the practice is very popular. So that makes you think that there is something there that's maintaining the use. There are also plausible neural mechanisms. So LSD clearly works on serotonin receptors, and that's also where our antidepressants work. And we know that high doses of LSD and other psychedelic drugs have some potential in the treatment of psychiatric disorders. And there's some very good preclinical evidence with rodents suggesting that low doses of LSD might have beneficial effects in animal studies. And so that basically comes from the group at McGill. On the other hand, it's very difficult to rule out the possible influence of expectancies. Nobody microdoses a drug repeatedly over a period of time, or even begins without having strong expectations that it's going to have certain kinds of effects. So it's almost impossible to rule out the influence of people's expectancies in their responses to the drug outside of a controlled setting. The mechanisms also, the neuroreceptor mechanisms of these very low doses are not really known. We know what the higher doses, how the higher doses act. We don't know about the lower doses, and LSD has actions on multiple receptor systems. So there may be a different constellation of effects at the very low doses. And of most concern is, as I've already mentioned, is the heterogeneity of the claimed benefits that people claim to benefit from. And here is just a sampling of some of the things that people have claimed. They've claimed an increase in creativity, energy, productivity, focus, social relational skills, leadership development. I won't read them all. Decreased depression, anxiety, menopausal symptoms. So it seems unlikely that any single medication is going to do all these things. Secondly, a lot of these are constructs that are very difficult to operationalize and measure in the laboratory, like health habits and quality of life, for example. So that makes it very difficult for us to study. And it also makes us a little bit skeptical that all these things can be happening. So there's a need for well-controlled studies. We need to know what exactly are the benefits or the effects of these low doses of LSD on either mood or on behavior. And then who benefits? So are there individual differences? In some people might experience one set of effects and other people others. So who benefits? Would it be people with psychiatric symptoms, or older or younger, or people with drug use history? At what doses and for how long? So this has been until now kind of a large natural experiment where people use it in the natural setting, but that we don't know how much they've tested different doses and different dose intervals, and whether the effects last beyond the dosing of the drug. And then the role of expectancy. So it could be that the expectancies in some way interact with the pharmacological effects of the drug, which is something that would be of interest to study. So what studies have been done until now? Quite a number of survey self-report studies have been done. So these are questionnaires that are usually on the internet, large numbers of people. And the question that's put out there is, do you microdose, and do you like the effects? Do you benefit from the effects? And these studies, not surprisingly, produce fairly uniform positive effects, and a whole, as I said, a very heterogeneous reports of what people actually experience. Of course, these are self-report studies are very much biased by the expectancy. So we don't know how much of that is really a pharmacological effect or a contextual effect. Then there was an interesting citizen science study done in 2021 where they asked people who were already established microdosers to blind their own drug in their own home setting. So they used their own supply of drug, and the investigators were able to blind it so the subjects could get either a placebo or a low dose of their regular drug or a higher dose of their regular drug. So they were able to blind the drug in their home environments. And here they concluded that the only people who really benefited from the drug were people who experienced enough a drug effect to be able to recognize the drug as a psychedelic drug or as their active drug. So they worried that this would break the blind, basically, that if they experienced a drug effect and correctly identified it as active drug, then they had to be excluded because they couldn't rule out expectancies. So you're going to hear this as a theme, this expectancies and placebo effects as a theme throughout this microdosing research. Then there is one, and I'll mention at the end, a study that used both mixed laboratory, sort of double blind, and used mixed laboratory session and naturalistic setting. So this was a study done by Murphy et al. In New Zealand, where the participants got their first session in the laboratory and then a remaining 15 sessions in their home environment. So I'll just show you briefly what they reported at the end. And what I'm going to focus on here now is laboratory-based studies that we've done in our lab. These studies are double blind, and I just like to spend a minute talking about what we mean by double blind. So we don't tell people you're going to get a psychedelic or placebo, period. We tell them you might get a stimulant, a tranquilizer, a psychedelic, a placebo, and we sometimes have other distractors in there, antihistamine, something like that. If we only told them psychedelic versus drug versus placebo, then anything that the people experience they would be set to expect to label that as a psychedelic drug. So we go out of our way to blind the drug administration so they don't know what category of drug they're getting. And this is especially useful at these very low doses because there's going to be ambiguity. So they might experience something and we want to know, is that psychedelic-like or not? We've done some studies with single doses and one study with repeated doses. And the measures that we get are behavioral measures. So how do the people behave? How do they report feeling? And then a few studies on their brain function as well. So as I said, the studies are double blind, they're placebo controlled. So in most of the studies, the same subjects get drug and placebo on separate sessions. There was one study, the repeated dosing study, where they were assigned to a drug group or a placebo group. The participants are healthy men and women. They're aged 18 to 35. They have to have used a psychedelic drug at least once in the past, and then and for no particular reason other than our caution as investigators. I don't think there would be any safety issue or any ethical issue, which is just something that we were careful about. They have to be normal weight, they have to have high school education, and then they participate in laboratory sessions in a comfortable living room-like environment for a number of hours for each session. So the first study was we wanted to know what those low doses do. And what the ideal here was to try and find a threshold at which the gold standard for microdosing would be to test a dose that's just below the detectability threshold. So the first thing we wanted to know was what's the dose response for these low doses? So the subjects had 4 8-hour sessions, and in mixed order under double-blind conditions, they got placebo 6.5 micrograms, 13 or 26 micrograms. So I just want to say a few things about how we go about selecting outcome measures. First of all, it's very difficult to measure threshold effects. If you're above the threshold, then in this case with microdosing, people say, oh, well, then the subject was able to identify the drug, and so then their blind is spoiled. If you're below the threshold and you don't see any effects, then you don't know whether there's any effect at all. So what you're looking for something that's almost impossible to measure. And I guess the ideal would be if you could get a dose where most people just feel an effect and then administer the dose just below that. One of the complications of that is that there's a lot of variability across individuals. So one person's, you would have to personalize that threshold dose in an ideal world. So it's just from a methodological point of view, it's really difficult to measure threshold effects. Then we're faced with a problem of what to measure. So as I said, the claims for microdosing have been very broad and heterogeneous. And so we're stuck with the problem of what exactly to measure, even whether we're below the threshold of detectability or not. What are the outcome measures that are going to give us the most sensitive effects? We struggle with this, and we work on it and try and get as broad a framework of questionnaires and tasks as we can. One global measure that we use with any drugs that we test in the lab is a measure of, do you feel any effect at all? So this will tell us something about whether we're above that threshold of detectability. So that's an important one, and it also allows us to compare to other drugs, whether the magnitude of the drug effect. Then there's also one questionnaire that's used, that's been developed specifically for altered states of consciousness. It was developed partly on self-reports of people's psychedelic experiences at high doses, and partly on other altered states of consciousness, like religious experiences and so. So this questionnaire turns out to be kind of the gold standard. It's what people use now to detect psychedelic effects. And I'll show you some of the questions. They're not what we normally measure in a kind of operational psychopharm lab, but you'll see what we did with it. So just to show you on the measure of, do you feel any drug effect? So this is that global measure. Over on the left, I'm showing you results from a group in Switzerland where they gave high doses. So they give 100 and 200 micrograms of LSD. And on the y-axis is a rating of it's a 100-millimeter line, and people indicate how much of a drug effect do you feel, from not at all to very much. So you can see that the high doses, 100 and 200, produce a pretty substantial effect, close to the maximum of 100. And then these over on the right are our doses of, we had placebo, 6.5, 13, and 26. And you can see that the placebo and the 6.5 are close to each other. And then you see a little bit of an effect at the 13 micrograms, and then a closer to a moderate effect at the 26 micrograms. So this is a guide for us to see what kinds of doses to use in our studies. And we've ended up doing some studies with using 13 and 26 micrograms. It's nice, though, to see that these are dose related. On the one hand, it's nice to see that they're nice and dose related. On the other hand, if I had shown you in this figure the variability across subjects, you would see that there's a lot of variability. And so some people, even at the 26 micrograms, some people are not experiencing any effects at all. So there's a lot of variability. It's just something for us to struggle with. Then on this 5-dimensional altered states of consciousness, I just want to give you a taste of what the questions are here. There's various subscales that are on the left there: unity, spiritual, blissful, and insightful. And here are some of the examples. I felt at one with my surroundings. I experienced a touch of eternity. I felt connected to a higher power. You can see from these questions, it would be difficult for any of us to rate ourselves on these questions. And it's hard to get a sense of what if you had a quantitative scale. I think their scale goes from 0 to 100. To what extent you feel one with your surroundings and what that's sensitive to. And so these are completely different, qualitatively different kinds of questions than what we've used in other studies with other classes, more familiar classes of drugs. So we just have to trust with them, trust that they will be sensitive. The other thing that always makes me puzzle with is in my lab, we do studies in humans that are sort of parallel to what gets done in animal studies, in rodent studies. And there's no way you could measure these kinds of subjective ratings in animal studies. So that it's a real challenge that for sort of translational work, that these experiences are completely non-translatable to rodent models. So this is what we have to work with, but we're moving forward in the field this way. These are the ratings on those questions for our doses. So this shows the 4 doses, the placebo, and then the 3 doses. These are ratings. And this scale, just to remind you, can go from 0 to 100. And I'm showing you here the ratings from 0 to 20. And these are the mean and standard deviation ratings of experience of unit. These are some of the scales. And you can see that the highest dose, that is the 26 micrograms, is producing a psychedelic or increasing scores on this scale of oceanic boundlessness. And it seems to be sort of a dose-related increase. So even at these very low doses, we're beginning to see some of these descriptors that are consistent with the higher doses, but at a very low level. But at least it gives us an idea, a little bit of an idea of what the drug might be doing under blinded conditions. So the second study, we wanted to look at brain responses to reward. And the reason we were interested in this is it's possible that the drug acts on the brain and changes motivated behavior, for example, even at doses that don't produce detectable subjective effects. So we want to know whether it would change an EEG signal that's been associated with sensitivity to reward. So we used something called the monetary incentive delay task, and we measured with EEG this with a signal that's called RU-P. Turns out that patients with depression exhibit a smaller RU-P. So this is consistent with a sort of dampened reward system. So people who are depressed have this smaller signal. And so our question was whether LSD might increase this RU-P signal. So we had 18 healthy adults, and they got 0, 13, and 26 micrograms. under blinded conditions in a within subject design. And this is basically the outcome of this study. So this shows the signal after the brain recording after a signal that says you received a positive outcome. It's a monetary reward, so you get money. And it's in milliseconds on the x-axis, and the y-axis is the magnitude of the brain response. The placebo response, so this is what on the solid line that's labeled placebo is what the brain does when it gets a signal that it got a reward. And you can see that both the 13 and the 26 micrograms increase that signal. So it's as though the reward is of a greater magnitude. So that's encouraging that it might be functioning in this way by sort of improving reward processing, and in that way might have a long-term effect. This effect was not clearly related to the people's subjective effects. So they reported some subjective effects at 13 and 26 micrograms, but it was not significantly correlated. So just to summarize that, the low dose increased, 26 micrograms increased the neural response to the signal for reward, and it was not highly correlated with what people reported feeling. The third study was looking at repeated doses. So the two studies so far were just looking at a single dose, but what people do in the real world is take the drug every 3 or 4 days. So it's possible that the responses to the drug change across repeated sessions. So we did this, simulated this across 4 sessions. So they were randomly assigned to one of 3 groups, a placebo group, a 13 microgram or 26 microgram group. They came into the lab every 3 or 4 days for a 6-hour session, 5-hour session, and they got either placebo or the dose that they were assigned to. And then we also had a post-test to see whether there were any lasting effects that were beyond the duration, that were outside of the direct drug effects. When we went into this, we didn't know whether any new effects would emerge over those 4 sessions. So would there be an accumulation of an effect that we would only see with repeated sessions, or whether there would be tolerance to the drug, or whether something would happen at the post-test. We included a whole range of different measures, so not only the direct subjective and cardiovascular effects, but also lots of behavioral measures of emotional reactivity and cyberball and all kinds of other behavioral tasks, both during the sessions and post-sessions. So this is one of the findings that we found. This was on the ratings of depression. So this is momentary ratings of depression. So how depressed do you feel right now on this questionnaire? And this is plotted as a peak change. So it's the maximum change from before they get the drug on that day to any time during the 5-hour session. So on the open bars are placebo sessions, and then you have low dose and then the higher dose. So that I'm pointing, although I don't think you can see it, but I'm pointing with my pointer that you can, on the first session, there was the drug appeared to decrease depression scores, but that dissipated across the subsequent 3 sessions. So we saw a decrease in depression that was dose related on the first session, but that was no longer there on the second, third. So this is suggestive of tolerance, and there's lots of evidence that there is rapid tolerance to the effects of LSD. Another measure is how vigorous do they feel. This is plotted in the same way, and you can see again on session 1, there was an increase, that 26 microgram dose increased self-reports of how vigorous do you feel right now, and that effect also dissipated across the 4 sessions. We didn't see any effects on the follow-up measure, and there was nothing that really increased across the 4 sessions. So we only saw this tolerance across sessions. So to summarize this study, we saw an increase in vigor and a decrease in depression, but only on the initial session or 2. And there were no effects on other measures of emotion or cognition. And then the 4th session, and the final one that I'll show you here, then we wondered, well, maybe we're looking in the wrong people. So all the studies to date have been with healthy volunteers, and there's some reason to start with healthy volunteers first. You want to know kind of basically what the drug does and how it affects the brain. But it could be that the claims in the natural environment are from people who have some pre-existing psychiatric symptomatology. So we decided to look at least at a single dose in participants who scored high or low on the Beck depression inventory. So we had a low BDI group who scored less than 17 on the Beck, and then a high BDI group who scored more than 17. I need to emphasize here that these people are not, they don't meet criteria for depression by any means. They're just scoring a little bit higher than normal on a questionnaire measure. They weren't excluded if they met criteria for depressive disorder, but that wasn't our goal in this. They had 2 sessions at 26 microgram and a placebo. First of all, let's look at the group's ratings of how much do you feel a drug effect. So this is the x-axis is the time across the session over minutes. And then the y-axis is a scale of 0 to 100 on how much do you feel a drug effect. The dashed line corresponds to the placebo sessions, and the solid line corresponds to the drug sessions. And the green is placebo, is the low BDI group, and the purple is the high BDI group. And they did not differ in the magnitude of their drug responses. So the 2 groups experienced the same magnitude of drug response. But then when we looked at a measure of positive mood, we saw something a little bit different. Over on the left, so here what I've plotted is their scores on positive mood before they get the drug. So they complete this questionnaire before they take a drug on a particular session, and then at repeated points afterwards. So this is the post here corresponds to the highest rating within the session. So if you start with the left, you can see pre and post. The low BDI groups are showing fairly high positive mood before and after on the placebo session, and fairly high positive mood on before and after on the LSD session. And there's no difference between the placebo and the LSD. On the right-hand side, you can see the high BDI group, and not surprisingly, on the pre-sessions, on the pre-measures, pre-drug measures, they score lower than the low BDI group. And you can see that the LSD produced a significant increase in their ratings of positive mood after LSD. So this is our first indication that there may be individual differences in response to the drug that are related to pre-existing conditions, in this case, depression. So it could be that people who have depressed mood have somehow a different brain neural function, and so the drug has a differential effect on this. And so I think this is kind of an exciting new open some new avenues of research. We would like to go ahead and look at this now with people who really meet criteria for depression, and then you could also look at it with other psychiatric symptomatology as well. We also looked at these 2 groups on that 5D ASC, the Oceanic Boundlessness questionnaire that's specific to psychedelic drugs. And here, just to kind of get you oriented, this is one of the subscales. The green bars correspond to placebo and LSD sessions in the low BDI group, and the purple are the high BDI group. And you can see already here that the LSD increased this ratings on this experience of unity in both groups, but it was really much greater in the high BDI group. So the high BDI group is reporting more positive mood and also more psychedelic effects, which we just had no idea that that would happen. And now I'm going to show you for the other scales, we saw a similar pattern. So a spiritual experience, blissful state, insightfulness, and total score. And you can see on each of these measures, the high BDI group are reporting more psychedelic effects. Now, why this is, we have no idea. And it will be interesting to see if it holds up with people who meet criteria for a real depressive disorder. We also administered the BDI 48 hours after each session. So after the placebo session and after the LSD session. And in the high BDI group, you can see that their depression scores decreased a little bit, whether they got placebo or LSD, but the decrease after LSD was greater. So this suggests that that decrease in depression might actually be lasting and outlast the direct effects of the drug. So just to summarize, this study compared to controls, we found that people with symptoms of depression reported greater acute effects, that is on positive mood, greater psychedelic effects on the altered states of consciousness, and lower BDI scores 48 hours after the LSD. So just to summarize what we've done here, that we can conclude that low doses of LSD produce transient, mild, usually stimulant-like subjective effects in healthy volunteers. They produce no effect on objective measures of creativity, emotional function, psychomotor performance. There's a possible increase in the brain's response to reward, and there's possible greater sensitivity in depressed individuals. I'm saying possible because these are single studies, so they need to be replicated and extended. I just want to say very briefly that this study in New Zealand had a much larger number of subjects, and they gave the drug for a much longer period of time. So they had healthy 80 men and women that were given either placebo or 10 micrograms every 3 days for 6 weeks. So they had a long study. The first dose they got in the laboratory, and then the subsequent doses they had at home. And they got self-report measures, they got measures of sleep, and they also got a neural measure of long-term potentiation, which might be a measure of neuroplasticity. They found that LSD, as in our study, that the LSD transiently increased self-reported feelings of well-being and energy. Interestingly, they found a novel finding that LSD increased sleep duration, not on the day of dosing, but the night after dosing. So this is something that has to be explained, and we don't have a clear explanation, but people reported, and they had objective measures of sleep as well. So there was a longer sleep the day after the drug session, and there were no effects on neural or behavioral measures. They had EEG measures and also no lasting effects, so consistent with our findings. So this is just a repeat of what I just said, that there were, I'm just repeating the same thing. Overall summary. So their summary was that microdosing elicited transient mood elevating effects. It was not sufficient to produce enduring changes in overall mood or cognition in healthy adults. So lots of questions remain. I think anytime you venture into new territory like this, you raise as many questions as you answer. So one of the central questions is, have we measured the right things? So we can measure mood effects, we can measure emotional responses, psychomotor performance. We may not have measured that critical element of what microdosing does. And are there other ways to measure the beneficial effects? Then do only certain people benefit from the microdosing? And then we had a little bit of a suggestion of that with the depressed people, that it might be effective for certain people or people in a certain state in their lives. Then we don't know when exactly the benefits begin and how long they last, and we don't know exactly what role expectations play. We also don't know what the neural mechanisms are that underlie these effects, and we don't know whether these effects that we're seeing at very low doses are related to the effects that we see at high doses. I'm sure you know, with high doses of LSD, there's a lot of discussion about whether it's the subjective experience that produces the beneficial effects or the direct effects of the drug. So if there's any kind of evidence that what we see with these very low doses of LSD is sort of neurochemically related to what you see at high doses, you might say, well, it's really what the drug does at the serotonin receptors rather than this powerful psychedelic experience that produces the clinical benefit. So we can ask questions about commonalities between the effects we see at these very low doses compared to high doses. And is there any promise of microdosing, for example, as a medication? So would there be any room to have a serotonin agonist at very low doses that could be used for therapeutic benefits? I want to acknowledge some of the people that have worked with me. Hannah Moeller, Anya Burshad were postdoctoral or graduate students, and other postdocs, other collaborators were very instrumental in this work. And we got funding from our internal Institute for Translational Medicine and the National Institute on Drug Abuse. So thank you very much for listening, and I'm happy to answer questions.
Thank you, Harriet, for your presentation. Who would like to ask a question? Come on, to the mic.
Hello, Harriet. Thank you so much for your lecture. It was very interesting.
My
Uh,
pleasure.
I want to ask a question. First of all, maybe correct me if I'm wrong. My understanding of a microdose, it should be that you don't feel that you are getting the psychedelic experience. If you feel it, then maybe it's not so much a micro. And how does it correspond with the 5-dimension scale, where there was like significant differences in what people felt? And I want to lead with like another question of, in the future, how could we incorporate it in our lives? Could we do this microdosing and feel a little bit of psychedelic and still do the job, our daily jobs, and continue with our lives?
That's lots of questions. Good questions. You know, there's a kind of a move in the field that has defined microdosing as sub-threshold, only applying to sub-threshold effects. The microdosing came from the natural world where people were doing it. And there was nothing in their reports of doing it that said you have to not feel any effects. It could very well be that the beneficial effects are only seen when you start to feel something. So the scientific world has come to define microdosing as below threshold of detectability. And I'm not sure there's any rationale for that. You might have to have a little bit of an effect to get whatever the beneficial effects are. So I would disagree with that. But the problem is then, of course, you can't rule out the expectancy. So that's kind of the bind that we're in. At the doses people are using, I don't see any reason why, even with a little bit of a drug effect, why it would interfere with your daily life. I mean, we want to watch out for that there aren't any safety concerns. There are some cardiovascular issues with, especially with psilocybin, a little bit less so with LSD. So we'd want to make sure that it was safe. But to my mind, at these very low doses, if they don't interfere with your daily functioning, I don't see any particular, unless you have moral objections to going through the day with a slightly altered state. I don't see that it would be problematic at these very low doses. That's probably politically incorrect to say that, but you asked.
Thank you very much.
So thank you very much for the talk. I was wondering, like, I would say that the word in the street is that some people are really responding to microdose and others don't. So I want to ask, if you look at the data, you have seen maybe more variance at the LSD group compared to the placebo group, or have you tried to look at like certain individuals that are responding?
Yeah, good question. I am interested in why some people respond and other people don't. I don't quite know where to look. I mean, we control body weight. We don't see differences between men and women. You'd want to look for a biological determinant of that, I think. We look at plasma levels, but those don't really account for differences in the subjective experience. So I don't know where to look exactly. Do you have a suggestion?
No, I was wondering about the variance between the two groups, between the placebo and the LSD groups. If there is like more variance in the LSD group, maybe some people are more responding than others, something like that. Like try to.
Most of our studies are within subjects, so the same subjects get drug and placebo. But you can still ask the question. Then we see a lot of variance with the drug session and not so much with the placebo session. What we are doing right now, it's kind of interesting, is looking at the individual items in the 5D ASC. So this is the psychedelic questionnaire. We're looking at individual items at 3 doses, at placebo, and then 6.5, 13, and 26, to see which items appear first as a sort of a signal for a drug effect. So it's something we're working on right now.
Thank you.
But the question of variability is an interesting one, and it would be valuable to know. I mean, we have like personality measures, we have cardiovascular measures. I don't know where to look to explain that variance.
Hi, Eric. Thank you so much for your talk. I did a few I'm presenting workshops about microdosing here in Israel, and I really got down very deep into this topic. And I want firstly to say that I really agree with you that we as a scientific community don't have any standards about what is microdosing and does it, can we say what it is objectively, like maybe it's a tenth of normal dosage, or maybe it's the way that we are consuming it, like every 2 days. So we're still trying to figure out. So firstly, I want to really say thank you for naming it a low dose, the 26 milligrams as a low dose and not as a microdose. So I think it's very important. This is first what I want to say. And what I wanted to ask is, I think that the element of set and settings is also very important in the subject of microdosing. And I didn't see any acknowledgement in this paper to the set and setting and to the subjective feeling and perspectives of the subjects that were in your study. So I want to ask you about what do you think about adding the set and setting notion to the microdosing study?
I would say that we are trying to minimize the influence of environmental factors. So we minimize the influence of expectancies, and the people are just in a comfortable environment. They're just being paid to participate in a drug study. That's all they really know. So we're trying, and it would be interesting at some point. It would be very interesting to do like a balanced placebo design where people are told they're getting they're told they're getting an LSD or told they're getting placebo, and then actually get, you know, a 2x2 design. So to look at expectancies per se. Then you can ask questions about the environment. So if they're alone or if they're with somebody else, and some of those things are testable. So if you put them together with another participant or with another person in the room, are the effects different? So my way of approaching set and setting is to start with a blank slate and then add pieces to that, the pieces that we have control over. And so another thing we could do is have them have a conversation, a conversation while they're under the influence, and the conversation could have either a deep component or a shallow component. So it could be it could be very personal or it could be not so personal. So my approach would be to start with a blank slate and then add pieces that you think might make a difference.
I'm sorry, I'm afraid we don't have any more time. Harriet, thank you so much for your presentation, and thank you for leaving us with curiosity and more questions.
All right. Thanks a lot. It was my pleasure. Thanks.